probably towards John, if you're there, or another colleague. That'd be great if you could. Thank you. Thank you.
Perfect. Okay, so I'll just admit these last few people. So there's loads and loads of topics, and we're unfortunately not going to get a chance to go through them all. Do you want me to start with a bit of a recap of what I look for on the chest X-ray? That's where I'd normally start. We'll have 10 minutes on that. I'll then start talking about consolidation. What other things do you guys want to see? So the topics that I've got pleural effusions, pneumothorax, heart failure, lung cancers, obviously the consolidation, essentially whatever you guys want you can have, but we're probably only going to have time for 2 or 3 topics overall throughout the hour. I'd rather do 2 or 3 topics and give you a little bit of depth rather than just skimming everything, otherwise you'll not really get anything from it. So I'll start with, if you guys are happy, I'll start with a brief overview. Consolidation and LVF, more than happy to talk on that. So we'll start with a brief overview of what I look for on a chest X-ray, and then we'll go on to consolidation and heart failure, and then just post up what other topics you might like to see, and James can sort of moderate as we go on. So okay, so I'll make a start. Just bear with me a second, guys, while I share my screen. Can you all see that screen? Is it quite small? Is it reasonable size?
Small but visible.
That's because it's on a packed screen. Just bear with me a second. I might be able to do something with that. I don't think I can actually. If people are struggling to see the screen, I can always zoom in on the images. So just shout up, James, if people are struggling. So we'll make a brief start on anatomy. So most of you will probably know that there's 3 lobes on the right: the upper lobe, middle lobe, and lower lobe. 2 lobes on the left: the upper lobe and the lower lobe. If we look from a posterior view, we can see how high the lower lobes come. So if I'm looking at a chest X-ray, for example, this chest X-ray here, I could have a nodule sat there, and that could be in lower lobe, because the lower lobe comes almost to the top of the chest. Likewise, on this side, I can have a nodule there, and it could be in lower lobe. Equally, I could have a lung nodule or a mass down here, and it could be in upper lobe, and that's because the upper lobes come quite far down, almost to the hemidiaphragms, and the lower lobes go almost to the top of the chest. You can see that a little bit more clearly on the lateral views. We can see sort of up to more than 2/3 of the way of the chest, the lower lobe comes, and the upper lobe comes right down to where we see the hump of the hemidiaphragm. So this is, you don't see any further below this point on a chest X-ray. So there's quite a lot of lung lies below the hemidiaphragm. So we take all these chest X-rays with a pinch of salt. So when we're saying the chest X-ray is clear, or there's no effusion or no mass or no consolidation, there's actually a large proportion of that lung that we simply don't see on a chest X-ray, and that's all down here. You've obviously got your fissures, your major fissures and your minor fissures, which I'll not spend too long talking about. And I'll not talk too much about that as yet. So it doesn't matter how you look at any X-ray, and this applies to musculoskeletal, abdominal, as well as chests. Everyone should have a criteria of how they review these chest X-rays, and like I say, it doesn't matter what area you look at, but as a general rule, the areas you need to cover are bones, pleura, mediastinum, hilum, the lungs themselves, the soft tissues, and then something called the hidden areas, the areas that tend to catch us out. So the way I will look at this, and you're paying attention to certain areas when you get certain clinical histories. So I'll pay more attention to the bones if someone comes in with trauma and I'm looking for rib fractures, for example. So I'm just tracing the outline of all the ribs, both posterior ribs and anterior ribs. When we see rib fractures, they mostly fracture on this lateral aspect down the side. A lot of people get hung up on these little indentations here and at this side here. And that's not a rib fracture. We don't often see rib fractures in adults posteriorly where they insert into the spine. What you've got there, you've got the transverse processes of the thoracic spine overlying the ribs. It's giving the impression that you've got little fractures at the medial the posterior aspect of these ribs. It'd be very, very rare to see rib fractures there in adult patients. So the place we're looking for rib fractures generally is around these lateral aspects of the ribs. I'm looking at the vertebra. We can see the thoracic spine through there, and we do pick up vertebral fractures on chest X-rays. Next, I'm looking at pleura. One of the important things in chest X-ray interpretation is being able to see nice crisp outline of both hemidiaphragms. We don't see it behind or through the spine, but we need to see a nice sharp crisp outline. This will make more sense when I come on to consolidation, but if we lose that outline, then there is a pathology touching that diaphragm. Likewise with the heart, we want to see nice crisp sharp heart borders, right heart border and left heart border. With at the bases, we want to see nice, sharp costophrenic angles. Let me just see if I can use my pen. So what I mean by sharp costophrenic angle is that sort of shape, a nice sharp edge. What I don't want to see is draw now. I don't know what this is. What I don't want to see is a costophrenic angle that comes down and then is blunted like that. Does anybody know what that might be if we get blunting of the costophrenic angle?
Pleural effusion?
Yeah, perfect. So that the reason that pleural fluid almost always pulls up to the side and tracks laterally is simply due to surface tension. Same as if you had a glass full of water and you looked at it closely, you'd see that water level tracking up the edge of the glass simply due to surface tension. That's exactly the same with chest X-rays. So we need to see nice, sharp costophrenic angles on both sides. That means we've not got pleural effusions. I'm then going to continue drawing up the side. I'm making sure that there's nothing white like that. That would mean there's something within the pleura. So there's a few things that could be. A patient with history of asbestos exposure, you'd be looking at pleural plaques or pleural masses, things like mesothelioma. A patient who's just fallen and had a fracture of this rib, that could be blood within the pleural cavity. So we're just making sure that it's a nice straight line up the edge of the ribs and there's no pleural indentations. We come up to the apices, and the things that I'm looking for in the apices adjacent to the pleura, I want to make sure that there's no pleural mass. Some of you might have heard of something called a Pancoast tumour. Pancoast tumour is not just one type of tumour, it's an overarching term for lots of different cancers that occur in the apex of the lung. So this lung, as you can see, goes nice and convex at the apex. What I don't want to see is a white mass looking like that. Sorry, it should be concave, which is what it is. If it starts to look convex like that, then start to think that there might be an apical mass, a Pancoast tumour up there. The other thing I'm looking for, I'm just checking that there's not a pneumothorax where the lungs started to collapse down there. So follow the pleura all the way around. Next, I'm looking at mediastinum. So by mediastinum, I'm looking at the trachea. I want the trachea to be nice and central. I don't want it to be deviated off to one side like that, for example, by a big white mass sitting here. elderly patients and occasionally younger patients do have thyroid goiters, so enlargement of the thyroid. Usually we can see them on multiple previous chest x-rays, and a good rule of thumb for anything on a chest x-ray is if something has remained stable for 2 years, we can usually ignore it. So if you have previous chest x-rays, that's a godsend to you guys looking at these. If it's not changed in 2 years, then you can be pretty confident that you can ignore it in most cases. Clearly there are exceptions to all rules. We do get slow growing tumours and the likes, but as a general rule, you can ignore these things if they've been there for 2 years. Or look back at CT scans. If you're not confident in looking at the CT scans, you can read the reports. And as a last resort, you can always ring us or email myself and Nick. We're more than happy to review chest x-rays and other imaging for you. The physios use us quite a lot. They contact us on a weekly basis to look at images for them. So we want a nice central trachea, which is what we've got in this case. Let me just see if I can get rid of my all these. So we can see here this black here. It's we can see that the trachea is nice and central. We know it's the trachea because it's black and it's air filled. The right branching into the right main bronchus there, and then the left main bronchus there. So that's a perfectly central trachea. This is the carina, so the bifurcation of the carina. Again, I'm then going to look at the heart. Most of you will have heard of the cardiothoracic ratio, sometimes written as CTR on a chest x-ray report. The cardiothoracic ratio can be measured on a PA chest x-ray. We don't measure it on an AP chest x-ray because the heart is artificially magnified on an AP chest x-ray. So when we're going up to the wards and doing mobiles and things, or if patients aren't well enough to stand up for a chest x-ray, we do an AP view, which is less than ideal. For the reasons I've mentioned. You get magnification of structures and artificial enlargement of structures. So the PA is the standard. What we're essentially doing, we're taking the widest point of the heart on both sides, which is there. I'm going to take that measurement there, and I'm going to divide it by the widest point of the inside of the ribs, which is there. I don't know why it won't let me. Can you guys see on your screen this left costophrenic angle? Is it visible?
Yes, it is on mine.
Yeah.
Yeah.
For some reason, it won't let me annotate down there, but I'm essentially taking this measurement and dividing it by this measurement to the other edge of the ribs. If the heart is less than half of the full width of the chest, then the heart is within normal limits. So we want it to be 50% or less of the heart, of the size of the chest itself. Now this is a youngish patient's heart, probably 40 or younger. We see gradual cardiac enlargement as people get older, go into heart failure, put weight on, and gradually, when this becomes 50% or more, we say the patient has an enlarged heart. Most enlarged hearts are due to left ventricular failure. You get that characteristic boot shape. So the right heart border remains normal because the right heart border is comprised of the right atrium. So this heart border is the right atrium. This left heart border here, this bit here is left ventricle. So most heart failure that we see on chest x-rays is left ventricular failure. So what we get is the characteristic boot shape where the heart, I don't know why it won't let me draw, but the heart essentially comes out into a boot shape like that. And that's where we see our enlarged cardiothoracic ratio, our enlarged heart. What next? So that's mediastinum. Next, hilum. That's the next thing I look at. So I think hilum is the hardest thing on a chest x-ray to interpret, so don't get too hung up on this. essentially 99.9% of both hilar are blood vessels. There's 0.1% comprised of bronchial walls and lymph nodes and blood vessel walls, but 99.9% of this and this is blood vessels. So they should look like blood vessels. They should be low density. We should be able to see through them. Mostly. I mean, even this, which is a little bit dense, we can see through it. We can see black lung behind it. What we don't want is any dense white mass, because that could indicate hilar lymphadenopathy or a hilar mass. But these look like blood vessels. So, for example, you can see this one, and it branches off to a smaller vessel there, comes down here, it branches there, there's another branch there, another branch there, down here they're branching there. Quick question, does anybody know what all these white lines are in the lungs? Anyone brave enough to have a guess? So often people will say that they're lung markings, which, yeah, that's what we call them. And then the next most common answer is airways, bronchi, bronchioles. But if we think about it, that's got to be wrong, because what colour is air on a chest X-ray? It's black. These lines are white, so these lines aren't filled with air. These are filled with something else. They're filled with fluid. So all these white lines, they're all blood vessels. All of these blood vessels come from the hilum. So the only thing that we should see in the lungs is blood vessels. We shouldn't see anything other than blood vessels. And as a general rule, all these blood vessels originate here and here. So they should all run roughly in the same direction away from the hilum. So you can see they do in this normal chest X-ray. We've got them running there, 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 there. These are going that way. These are going that way. What I don't want to see is lines that are running that way, because that wouldn't be in keeping with the normal direction of blood flow away from the hilum. Something wrong with my pack screen in there. So all these white lines, they're all blood vessels. The next thing to know with these blood vessels is that there's more of them in the bases than there's the apices. And if I zoom in, if it'll let me, if I took a measurement, if I took the diameter of these blood vessels, the diameter of these would be thicker than the diameter of these. These are quite thin blood vessels in the upper zones, and these are a little bit thicker. Anybody know why that might be? It's as simple as being due to gravity. If we stood the patient on the head, then the blood vessels would go up to the apices. When we do a supine chest X-ray, we lay the patient on the back and take a chest X-ray. The blood vessels are evenly distributed into the upper zones and the lower zones. So on a normal chest X-ray that's taken erect, which most chest X-rays are, more of the blood vessels will go down to the lung bases than in the apices. One feature of heart failure is something called upper lobe venous diversion. So due to increasing pressure within the lungs and increasing arterial pressure, we get the blood being diverted into the upper zones. I've got a few examples of this later, but if you start to see thickened and engorged blood vessels, sort of similar diameter to these down here, if you see those in the upper zones, then you need to start thinking whether the patient might be in a degree of heart failure, because we'd seen that there's diversion of the blood into the upper lobes rather than the lower lobes. So that's hilum and blood vessels. The next thing, I just quickly scan through the lungs, and I sort of, this is what I do with my eye. I'm just going backwards and forwards, and I'm just checking that everything in those lungs is a blood vessel. You start to see little densities, these little white densities. All these are the blood vessels end on, so they're either coming towards you or moving away from you. Remember, we're looking at a 3D structure on a 2D image, so I don't want to see anything other than things that I can characterized definitely as blood vessels. Again, I've come to a little white dot there. You can see the blood vessel that it's part of. So the vessel is running parallel to the image, and then it's coming towards you at that point. Again, here you've got a little density, but it follows the blood vessels. The blood vessels going parallel to the image and then coming towards you and then continuing on. Same here and here. You can see this is blood vessel going down here. It then gets to that point and branches up and down. Again, here and here. These are all end-on blood vessels. On your PACS systems, if you review these images on PACS, you'll have a measurement tool. We don't use it very often, but one way that you can use the measurement tool is to measure the size of these blood vessels. Now, just for example, this one probably measures about 1 millimeter. This might be 2 or 3. That's probably about 3. As a general rule, we can ignore any nodules that are less than 5 millimeters. If they're less than 5 millimeters, then they're either an end-on blood vessel or they contain calcification. And if they contain calcification, then they're not malignant, so we can ignore them. Calcification doesn't happen overnight. It takes months and years to occur. We can ignore anything that's less than 5 millimeters because it's, like I say, either an end-on vessel or it contains calcification. It's those nodules that are between 5 and 1.5 centimeters, 5 millimeters and 15 millimeters that are the hardest to see on chest X-rays. You might be asking the question, well, what about those lung cancers that are less than 5 millimeters? Well, the fact of the matter is you simply won't see them on a chest X-ray. A chest X-ray doesn't show enough detail to be able to pick up a lung nodule at less than 5 millimeters. You'll have to trust me on that for now, but I've got some images to back up what I am saying a little bit later. So I've looked through the lungs and I'm happy there's nothing in the lungs. I'm going to have a quick look at the soft tissues. So I'm looking... there's not really much goes on in the soft tissues. You might get some subcutaneous emphysema if a patient's had a chest draining or a line inserted or they've got a pneumothorax. I'm looking at the soft tissues below the diaphragm. The right hemidiaphragm is always slightly higher than the left. That's because the liver's pushing this one up and the heart's sort of pushing that one down. The left one usually contains a little bit of gas. That's the stomach bubble. We can see a fluid level there, so that's whatever the patient's just eaten sinking to the bottom of the stomach, and this is gas within the stomach. I'm looking for signs of pneumoperitoneum, so perforation of small or large bowel can let gas escape, and that gas would then rise and it would sit as a thin slither of gas a couple of millimeters below the hemidiaphragm. What else am I looking for in soft tissues? That's probably about it. And then I come to my hidden areas. So there's 4 hidden areas on chest X-rays. So there's the apices, which we've already mentioned. Most lung cancers occur, 3/4 of lung cancers occur in the upper lobes, and a lot of those are in the upper zones up here. It's made more complicated by the fact that you've got lots of overlying ribs up here, more so than we have down here. So these are called lawyers' zones because that's the areas where we miss these lung cancers. It's where the lawyers like to jump on people who have missed them. Another area too where we miss cancers and masses are the hilum. So the left hilum is often slightly higher than the right hilum and looks slightly denser as well. That's because the left hilum comes up and over this left main bronchus, so it goes round the back and comes up and over, whereas this right hilum goes down and underneath the right main bronchus. So this always comes slightly higher. They're about the same height in this example, but 99 times out of 100, the left one will be slightly higher than the right. The hilus should be low density. They should look like blood vessels. What I don't want to see, so textbooks might say that these blood vessels should look quite concave, so they'll look like this and have lots of concavity. What I don't want to see is what the textbooks call a lumpy bumpy hilum, and that is a convex appearance indicating a mass or hilar lymphadenopathy. These are quite low density. What I don't want to see is dense whiteness around this area, again suggesting there's increased density either due to a mass or lymphadenopathy. Two more hidden areas. One is behind the heart border, so we're going to look behind here. It's important to window your image so that you can see behind there. There's been plenty of nodules and masses sitting around there that try and catch me and my colleagues out. And again, I did say at the beginning that the lungs actually come down quite a lot further than the base of the film. The lungs will go quite a lot lower than that point, probably by a couple of centimeters. So again, there's been some remarkable cases in textbooks and in journal articles where a lung nodule has been identified through the stomach bubble, and it's pure luck that those things have been identified and that the patient's got gas in their stomach at the time of the chest X-ray. And that's about it for the very basics. I'll just end the show and I'll come back to see if anyone's got any questions. Just discard that. Right. Were there any questions there, James? I heard. No.
No, none from the chat. Anybody that's in the meeting at the minute? Anybody who got any questions?
Hi there. Can you hear me?
Yes.
Hi, I'm Kirsty, one of the trainee ACPs, the Northern General. I'm just asking on ITU. I'm just asking. I noticed it's been recorded. Will we be able to access the recording? Because me and my colleague got a bit waylaid, so we've come a bit late to the party.
I'll let you answer that, James.
Yeah, we'll make sure it's shared. Kirsty, we're not quite sure in what way we'll share it, but Helen, myself, John, or one of our colleagues will make sure it's available to you.
Oh, perfect. Thank you.
And Rob, there's a question from Lorenzo in the chat. I don't know if you can see that if you're not sharing your screen.
Yeah, I can see that. No, I'm not aware of any mnemonics, unfortunately. But I don't know if you want to write it down, or in fact, I'll just type it in so people can see it. But it's bones, or Idiostine. Areas times 4. So there, as long as you go through those every time you look at an image, then you should be looking at everything on the image. There's everything covered there. Okay, so we'll talk about consolidation. Let me just see if I can share my screen again. Right, can you see that, guys?
Yep. Yeah.
Perfect. So
Yep.
the silhouette sign. So as it says, it's one of the most important concepts in radiology, not just chest X-ray interpretation. But if anyone's looked at an abdominal X-ray, for example, it's really hard to see kidneys on an abdominal X-ray. The kidneys are filled, they're soft tissue density, and they're filled with fluid. They're adjacent, they're in the abdomen. The abdomen itself is soft tissue density filled with fluid. So because they're of similar density, you don't see them because they don't form a silhouette or an interface between them. The reason that bones stand out so well on X-rays is because bones are dense. They're adjacent to a less dense structure, which is the soft tissues, which is adjacent to an even less dense substance, which is the air, and that's why we get interfaces between structures. So loss of the silhouette sign or loss of an interface can help determine the position of a disease process. So I started by saying that when we see nodules and things, it's really hard for us to say which lobe they're in because they can be a lung nodule, for example, could sit up here, and it could quite easily be within the posterior segment of the lower lobe. Equally, a lung nodule could sit down here, right adjacent to the hemidiaphragm, and it could be within upper lobe. So, but there are ways in which we can say where things are. This might be worth making a note of. So if we lose, when I say lose, I mean lose the crispness and the sharpness of this hemidiaphragm. I started by saying that we need to see a nice, sharp, crisp outline of both hemidiaphragms. Even behind the heart body, you can see you've got a nice, crisp outline of that hemidiaphragm. And again, same with the heart border, you need to see both outlines nice and crisply of both heart borders. If we lose the right or the left hemidiaphragms, that pathology has to be in one of the lower lobes, because if we look at the lateral views, only the lower lobes come into contact with the hemidiaphragm. If we lose the right heart border, that pathology has to be within middle lobe, because there's only the middle lobe touches the right heart border. Left heart border is left upper lobe, and that'll make more sense when I show you a few images. So we've got two hemidiaphragms, two heart borders. Can anyone tell me which heart border or which hemidiaphragm interface we've lost there?
The right heart border.
Perfect. So that pathology, which again we'll come on to in a few minutes, it's consolidation that, but we can say that that is within middle lobe, because only the middle lobe comes into contact with the heart border, the right heart border. So we've got right middle lobe consolidation in this case. Ignore the windowing, but which heart border have we lost in that case? Left. Hopefully you can all see that. So that we can't see that left heart border at all. The right heart border is there, and the right hemidiaphragm is there. I've had to window it because I wanted to show these black lines on a later slide, but the right heart border is there, the right hemidiaphragm is there. We've only lost those because I've windowed it. This left heart border is completely lost. We've lost that interface. So can anybody tell me which lobe that pathology is in? Is it left upper or lower?
Upper.
Perfect. Yep. So whatever this pathology is, and it's consolidation again, and we'll talk about that in a few minutes. So we can say for certain this is left upper lobe consolidation. The hemidiaphragm is completely preserved. There's no consolidation in that lower lobe there. Okay, so which hemidiaphragm or heart border have we lost this time? This is slightly harder.
Left hemidiaphragm.
Perfect. Yeah. So that example that I showed you earlier, we could see the hemidiaphragm even behind the heart border. So we can just see a little bit of the lateral aspect of the hemidiaphragm where there's no pathology there, but we've lost all this aspect of the hemidiaphragm. So again, this is consolidation, and it is in the left lower lobe because only the lower lobe is in contact with the hemidiaphragm. We can see the left heart border even overlying the consolidation, because the consolidation is not in the upper lobe, it's in the lower lobe, so it's touching the hemidiaphragm, it's not touching this heart border at all. Don't think we need to talk about that just yet. I'll skip forward to consolidation. So consolidation is also called alveolar shadowing, airspace shadowing. They're the main ones. It took me about 6 months of my chest X-ray reporting course to realise that alveolar shadowing was the same as consolidation. I kept trying to work out what the difference between them was, but they're exactly the same thing. So we've already talked about that. So and we've looked at these examples. So I'll skip past that. So point to take from today: alveolar shadowing is exactly the same as alveolar disease, airspace shadowing, and consolidation. They're all the same thing. Essentially, what consolidation is, it's something within the alveoli that's not air. We can't say on a chest X-ray what that is within the alveoli, because all it is to me is a white density that's replaced air within the alveoli. So, for example, this patient, this is consolidation. If you tell me on the request card that the patient has just been stabbed in that right side, then I'll tell you that that's blood within the alveoli. If this patient is a youngish patient in their 20s, 30s, 40s, and they've come in with a productive cough, a temperature, sputum, raised white blood count, then I'll tell you that that's pus or infection within the alveoli. If you tell me that this patient is in their 80s, has smoked all their lives, they've had hemoptysis for 6 months, they've had weight loss, they've got a load more red flags, then I would tell you that that's potentially an alveolar cell carcinoma, and it's malignant cells within the alveoli. So there's lots and lots of different causes of consolidation, and they all often look very, very similar. What we're heavily reliant on is a good clinical history, so that I can tell you on the report what I think that is. Often we can't be specific, but sometimes we can. So this bottom line is important. It's impossible to differentiate the material radiographically. So we could have blood plus water cells, protein, or a combination of the above. Essentially, consolidation is simply fluid or cells within the alveoli. Okay, so what does consolidation look like? We don't get many straight lines with consolidation. It should be, the textbooks tend to say it looks like cotton wool, so it's fluffy, it's ill-defined, it's poorly demarcated, and we get something called an air bronchogram, which I'll come on to in a couple of minutes. So if we look at this is consolidation. There's no straight lines here. It's fluffy, it's ill-defined, it's patchy, it's white. Consolidation is always white on a chest X-ray. So this is a classic consolidation. So that's going to be consolidation within the left upper lobe, because we've lost that left heart border. Sometimes you can't, if we don't lose a heart border or don't lose a hemidiaphragm, don't worry. It just means we can't say exactly which lobe that consolidation's in. It's usually not that important to say which lobe it's in, because if it's a chest infection in the upper lobe or a chest infection in the lower lobe, we're going to treat them the same anyway. This one's a little bit more difficult, but you can see we've got a little bit of white fluffiness here in the periphery of the lung. There's more than just blood vessels there. If I zoom in a little bit, these are not just blood vessels. These lines here, these are blood vessels. There's more than blood vessels there. This straight line, that is the horizontal fissure. We've got thickening of the horizontal fissure because we've got a little bit of pleural fluid, which is likely an inflammatory reactive response. We've got a little bit of fluid buildup in that horizontal fissure due to this infection that's adjacent to it. Again, this is not just blood vessels here. We've got a bit of patchy whiteness here. And I think there's probably a bit more than just blood vessels here. I think this is consolidation down here. So we've got patchy bilateral consolidation in that example. Here, this whiteness, again, is consolidation. We've lost the right heart border. This straight line is because the consolidation has gone right up to the horizontal fissure, and it's abutting the horizontal fissure. But when a consolidation abuts the horizontal fissure, that's the only time when we would get a straight line with consolidation. We don't, excuse me, we don't get straight lines with consolidation unless it abuts this fissure. So yeah, so we've got consolidation there, a bit of patchy consolidation here as well. This one, again, is consolidation. Has anybody heard of an air bronchogram before? So an air bronchogram is essentially reversal of the silhouette sign that we discussed earlier. So normally, if we ignore the right lung and only look at this left lung, this normal left lung, we see these white lines. They're blood vessels, as we've discussed. You don't very easily see airways on a chest X-ray. You just see the overall blackness of the alveoli. So all that blackness, or most of it, is contributed to by air within alveoli. That's where most of the air is. If you look very, very closely, you might be able to pick out a couple of airways, but it really is difficult to identify. The reason it's difficult to identify is because we've got air next to air. We've got air in the bronchi next to air in the alveoli, and we don't have an interface. They're of similar densities, therefore we don't have an interface, same as the kidneys in the abdomen. If you fill all these alveoli with fluid, which is what we've said consolidation is. So with consolidation, you fill these alveoli with fluid, you then create an interface between the alveoli and the bronchi and the bronchioles. So here, can you see these little black lines? I'll zoom in. These black lines here. A bit low resolution, unfortunately. But these are what's termed these are what we call an air bronchogram. So we're seeing the airways because we've created an interface between the air-filled airways and the fluid-filled alveoli. This is a perfect example of air bronchogram. All these little black lines, these are the airways which normally you don't see on a chest X-ray. So you've created an interface because we've filled the alveoli with fluid throughout the entire hemithorax, and now these airways, which normally you wouldn't see, we've created an interface so you see them. Does that make sense?
Yeah.
Perfect. So the only pathology that gives us air bronchograms is consolidation. So if you ever see these black lines, then it has to be consolidation. You don't get air bronchograms with masses or nodules or cancer. You don't get air bronchograms with collapse of a lung or collapse of a lobe. You don't get air bronchograms with pleural effusions. You only get air bronchograms with consolidation. So if you see these, you know it has to be consolidation. So this might look like a pretty scary chest X-ray, and you might think, oh, how do I start by interpreting this? Well, you've got your answer straight away. You've got air bronchograms. This is consolidation. This is consolidation, probably due to fluid within the alveoli. Again, on this left-hand side, it's not as bad as the right, but you've got this patchy, fluffy whiteness, cotton wool type appearance. Again, we've got consolidation in the left mid zone and the left lower zone as well. This is a child. You can see the epiphyses have not fused the heads of the humerus. This is a child. Almost certainly this is due to a chest infection that's probably started in the right lung. It's overtaken the right lung and it's spread into the left lung as well. So this is a bilateral pneumonia, most likely in a child. This one, again, patchy, white, fluffy in the lower zones bilaterally. Again, that's consolidation. And again here in this left lower zone, patchy, white, fluffy, ill-defined, that's consolidation. Again, this is an air bronchogram again. We've filled the fluid, we've filled the alveoli with fluid. If you see an air bronchogram, it has to be consolidation. So this is consolidation in which lobe? Does anybody want to have a guess?
Left.
Left upper. Perfect. Yeah. So this is consolidation in the left upper lobe. We know it's left upper lobe because we've lost that heart border, and only the upper lobe is in contact with the heart border. So again, quite a scary chest X-ray to first look at, but when we know what we're looking for, it's quite easy to say this is consolidation in the left upper lobe. Yep.
Can I just jump in? Richard's got a question, which was going back to the paediatric X-ray a minute ago.
Yep.
And the question was there a double heart border on that child's X-ray? That's the question.
Double heart border. What do you mean by
there's Richard with his camera on. Got Rich, I'll hand over to you if your mic's working.
I'm wrong. I just thought I could see two lines. That's I'm pointing at it, but you can't see.
We're looking at left or right sided?
Left. I can see like a concave line, which is the true left heart border, and then I can see another one that seems to follow it back from that, but I don't know if that means anything.
Are you looking? Try and direct my mouse pointer. Am I going that way? Or?
Left there.
Where, sorry?
Left. There, I can see an arc. I don't know what that is.
This?
Yeah.
So that is another air bronchogram. So that's an airway. You can see it branching there, coming down here, branching there, branching there.
Okay.
You might not be able to see as well as I can. I'm seeing this on a PAC screen, so it's good resolution. But yeah, it's just one of the first things that we learn when we're learning how to interpret chest X-rays is how our eyes play tricks on us. You can see these like black lines here, and it's just essentially the ribs create your eyes make patterns, so we try and learn to ignore these things. But yeah, you've just essentially got an airway, another air bronchogram, and it's creating your eyes trying to make a line out of it where really there isn't one.
Cheers.
No worries. So very briefly, so causes of consolidation. Generally, infection will be unilateral. I mean, we've said it can spread to bilateral, but most chest infections will start on one side, and then when they get bad enough, they will spread to the other lung. So if you see unilateral consolidation like this, for example, that's usually due to chest infection, especially in a young patient. This again is likely to be a chest infection. Things that let's keep going. If I aspirate my glass of water while I'm sat up, most of the aspirate will go down into my right lower zone, because my right main bronchus is a steeper incline than this left main bronchus. So whenever kids aspirate marbles and things, they tend to go down this right into the right lung. I'll just highlight that. Let's do it again. So most things will naturally go down that right side. The left main bronchus comes across at a slightly more acute angle. So anything going down there, most of it will continue into this right lung. So a marble will impact there. If I aspirate, like I say, my glass of water, it will all start pooling down here. So if I aspirate when I'm stood up, that's where it will go. So I'll get consolidation down here. If I aspirate when I'm laid on my back, so these patients on the wards in beds when they're given food and drink when they're supposed to be nil by mouth, that goes into both lungs evenly. Let me get rid of these. This is a case of a patient aspirating while they're laid on their back. It's gone into both perihilar regions and lower zones quite evenly on both sides. So this patient unfortunately tried hanging themselves. They were brought into resus and then they vomited while they were in resus. So this is aspirate whilst the patient was laid in resus, and the aspirate has gone into both lungs relatively evenly. So this is aspirate when laid supine. Things like pulmonary edema and fluid overload, do we think that would be unilateral or bilateral? The answer is yeah, perfect. So bilateral and relatively symmetrical. So things like fluid overload, pulmonary edema, they're more systemic conditions rather than just relating to the lungs. There's no reason that edema or overload would affect one lung more than the other. So those tend to be relatively symmetrical and bilateral. Acute respiratory distress syndrome is bilateral and symmetrical. Lung contusion is usually unilateral at the site of trauma and rib fractures. Obviously, if a patient's had trauma on both sides, then it would be bilateral. So we can narrow down our differential by saying whereabouts this consolidation is. So I hope that helps. I've unfortunately rattled on quite a lot, and we've only got 5-10 minutes left. So I'll quickly touch on heart failure. One thing which I will say is that I'm happy to do these teaching sessions more often. I'm happy to do one a month, for example, if you guys have found this useful, and we can slowly work our way through these 191 slides, provided you're not all bored to death of listening to me. So let me just find heart failure, and then I think we'll call it a day. Any questions so far? Good.
None, but a few people wanted to take up on the offer of the regular teachings, Rob. So thank you for that offer.
No problem at all. Right, okay. So we've already said that the right heart border is made up of the right atrium. The left heart border is made up of the left ventricle. Most heart failure that we see is left ventricular failure. So we get this characteristic boot shape, which gives us our increased cardiothoracic ratio. And I've already touched on the fact that the cardiothoracic ratio shouldn't exceed 50% of the whole width of the chest. That's on a PA chest X-ray. If we turn a patient AP, we can still sometimes say the heart's enlarged if that heart border touches the ribs. So on an AP chest X-ray, if that left heart border touches the ribs, we can say that there probably is cardiomegaly, even allowing for the AP projection. So what do we see with left ventricular failure? So we see cardiomegaly. We get a cardiothoracic ratio of over 50%. We see upper lobe venous diversion. This is the first sign of heart failure, and it's overlooked so often. Unless you report chest X-rays like we do in radiology, I would imagine most people in the trust wouldn't know what they were looking for with upper lobe venous diversion, despite the fact that it is usually the first sign of heart failure on a chest X-ray. Pulmonary edema. So we get a couple of different types of edema. We get pulmonary edema, which is edema in the alveoli, and we get interstitial edema. So we get fluid building up in the interstitium of the lungs. So the interstitium is the scaffolding surrounding the alveoli. I think I've got some examples of Curly B lines. There's Curly A lines, Curly B lines, and Curly C lines. The only ones that are important are Curly B lines, so you can ignore the others. Two types of alveolar shadowing. We get gravity dependent consolidation, which falls to the basis, so we get bibasal consolidation. And you sometimes get a bat wing or angel wing appearance. Some textbooks call it bat wing, some textbooks call it angel wing, and that's a bilateral perihilar consolidation. Again, this will make more sense when I show you some examples. We get small bilateral pleural effusions with heart failure. So when these patients are in left ventricular failure, they start to accumulate fluid in gravity-dependent places. So they come in, they've got swollen calves. They come in, they've got bibasal consolidation. That consolidation usually goes to the bases, and we get bilateral basal pleural effusions. Fluid starts to accumulate in the pleural cavity as well as the alveoli. Peribronchial cuffing. Quite a few of my colleagues like to talk about peribronchial cuffing on chest X-rays. I don't so much. The signs are really subtle. It's often overcalled, and I think if you've got peribronchial cuffing on a chest X-ray, it's often not enough for you guys as clinicians to treat. So it's sometimes the very early stages of heart failure and fluid buildup, but it's often not enough to treat. And I'll talk a little bit about all of those in a minute. So as we get rising arterial pressure due to the heart failure, we get upper lobe diversion as the first stage. We get these Curly B lines and interstitial edema. Most patients won't have Curly B lines. I probably only see Curly B lines in 1 in every 20 heart failure cases. Cardiomegaly I see all the time. Pleural effusions I see very commonly, and alveolar edema or consolidation I see quite commonly as well. So we've already talked about upper lobe venous diversion, and we're looking at the diameter, the width of these upper lobe vessels. We already said that the lower lobe vessels are thicker in diameter than the upper lobe vessels. This left-hand image is a normal chest X-ray. This right-hand image is a patient with heart failure. It's actually the same patient. This is before the patient went into heart failure. So we've got nice thin upper lobe vessels. You can see in this case they've become engorged, and you can definitely see that there's more prominence of these upper lobe vessels. The vessels have increased in diameter. The blood's been forced into the upper lobes due to rising arterial pressure. Curly B lines, so again, normal image on the left here. One thing I forgot to mention right at the start is that in general, we don't see anything in the outer 1 centimetre of the lung. So lateral to this line that I'm drawing now, we shouldn't see any lung markings in most cases. That's simply because the lung markings, these blood vessels, they're just too small to see right at the very periphery of the lung. They are obviously there. They're often too small. You might get the odd one creeping in, but in general, you shouldn't see very much in the outer 1 centimetre of the lung. Here, you've got lots going on in the outer 1 centimetre. You've got all these horizontal lines. You only really see these in the lung bases. But these are what we mean by curly bee lines. This is fluid building up in the interstitium around the lung. So that's a good example of curly bee lines. So we've got two types of consolidation. Unfortunately, this is in the way here, but we've got some consolidation down there and down there. That's gravity dependent, so it's bilateral lower zone consolidation. This is perihylar or bat wing or angel wing consolidation. We've got bilateral, relatively symmetrical consolidation around the hilum. We see this gravity dependent a lot more than we see the angel wing or bat wing appearances. Small bilateral effusions, so this time we've got fluid tracking into the horizontal fissure, and it's 6 o'clock, so I'll just show you a few images of heart failure, just so you can get your eye in for it. So here I've not got a measurement tool on this presentation, but if I took the cardiothoracic ratio, that heart would be more than 50% of the width of the chest. Hopefully everyone agrees. So we've got the first sign, we've got cardiomegaly. These upper lobe vessels are engorged and dilated, so that's the second sign of heart failure. We've got upper lobe diversion. We've got consolidation down here and down here. Hopefully everyone agrees that there's more going on down here and down here than just blood vessels. So there's consolidation. It's white, it's fluffy, it's ill-defined. It's exactly how we expect consolidation to occur. It's bilateral, it's symmetrical. So we've got bibasal consolidation. That's the third sign of heart failure. The fourth one, small bilateral pleural effusions. We've got fluid tracking laterally. We've got that meniscus, which someone described earlier. So we've got small bilateral pleural effusions as well. So we've got all four features of heart failure in that patient. So that's a perfect classic example of heart failure. Next one. So this is an AP projection, so always be wary when you're looking at the heart on an AP x-ray, but even allowing for the AP projection, this is a massive heart. Even if we turn this patient PA, I suspect this heart would be enlarged. So we've got cardiomegaly, we've got definite upper lobe diversion, we've got consolidation, so again it's white, it's fluffy, it's ill-defined, it's bilateral, it's lower zone. That's the third sign. The fourth one are small effusions. We're losing our costophrenic angle. Our costophrenic angle should come right down to the ribs. We're losing it. The costophrenic angle looks like it's starting here when really it should be here. So this is a pleural effusion tracking laterally. If I zoom in, you can see this white dense edge. That's not a rib. That's pleural fluid tracking laterally. And again, if we go to the other side, this white density here, again, that's not a rib. We can see through ribs. You do get a rib edge on every rib, but you can see through ribs. You can't see through this. This is a pleural effusion. The whiteness of an effusion you shouldn't be able to see behind. So we've got cardiomegaly, we've got upper lobe diversion, we've got bilateral lower zone consolidation that's relatively symmetrical, we've got small bilateral effusions, we've got all four features of heart failure. Next one, again AP, but that heart's enlarged even on an AP view. So we've got cardiomegaly, these upper lobe vessels are engorged. We've got consolidation, there's more than just blood vessels going on down here. It's white, it's fluffy, it's ill-defined. We've got a meniscus there, we've got a meniscus there. So we've got, again, all four features of heart failure. Just bear in mind, I'm showing you the classic appearances today. Sometimes you only get one or two of these four, sometimes you get all four. The more you have, the more confident you can be in saying that that's heart failure as opposed to something else. Again, it's AP projection, but that's a big heart. The upper lobe vessels are engorged. This is consolidation, this whiteness here. That's not just blood vessels. This is not just blood vessels. It's white, it's poorly defined. We've got a meniscus tracking up there. We've got a meniscus tracking up there. Classic heart failure. This one, again, AP, but it's a big heart. Upper lobe diversion. Consolidation is a little bit more difficult to identify here. I think there is consolidation. I think that it's really hard to put your finger on. It's probably only experience that's telling me that there's probably a bit of consolidation here. I can't really put my finger on it, but the blood vessels just look a little bit busy down here, especially. I can't easily see behind that left heart border, suggesting that there's consolidation down there as well. This is an effusion. Again, that's not a rib. We can see through ribs. We can't see through this. This is an effusion tracking laterally. And again, same at this side. We've got blunting of that costophrenic angle, small effusions. And I think we will leave it there. We'll not start talking about fat pads and other things that'll confuse you. So I'll end that there, but we can pick this back up again next time. Can I just get a little bit of feedback in terms of, was that aimed roughly at the right level? I'm going to stop sharing my screen with you now. Was that aimed roughly at the right level?
Yeah, well, thank you.
Good. Okay, so I hope you found that useful. Apologies that we've only had an hour and we've not had time to go through any more. I'd love to bore you with all 191 slides. But yeah, James, I don't know if we want to catch up tomorrow or next week and get some other dates in the diary. I'm more than happy for this to be shared as wide as you want. It makes no difference to me whether I'm teaching one person or 100. With Teams, it's quite easy to do the teaching. So yeah, I hope you all enjoyed it, and thank you very much. And James, we'll pick up tomorrow or next week.
Yeah, we'll catch up. Lots of thank yous in the chat, Rob. One question from Lorenzo about looking at skull X-rays. I think is that Lorenzo. I don't know if you want to come in for that one or not. But that was just one of the questions in terms of future teaching. I think we explore other anatomical X-rays like skull. That's the question.
I can. I don't. If are you there, Lorenzo?
Say again, sorry.
In terms of skull X-rays, what particularly what were you thinking in terms of skull X-rays?
Oh, just because I work in neurology, so you know, sometimes send people for basal skull X-rays or cervical X-rays.
Okay, yeah,
X-rays.
That's absolutely fine. Yeah, we can do that. That might be better unless there's quite an interest for skull X-rays. We don't actually do very many skull X-rays unless it's people like you, Lorenzo, who's requesting them. In general, I think I only look at one skull X-ray a month probably now, because we've just sort of phased them out. Most patients who would have come for a trauma series to include skull X-rays, if anyone with head injuries now, they don't get skull X-rays, they go straight to CT for a CT head scan. So we've massively in the last 5 years almost completely stopped doing skull X-rays. We do the occasional ones for specialists such as you, Lorenzo. So I'm happy to do some specific teaching for you. If you want to get in contact, just drop me an email or come through James. But I suspect skull X-rays won't be that useful for most people. But I'm happy to.
Yeah, thanks a lot. Thanks a lot.
Yeah. Okay. Yeah, getting some good feedback, so I'm glad everybody has enjoyed that. And great. If there's nothing else, I'll get off.
Thank you.
No problem.
Yeah, thank you, Rob, and thank you everyone for joining. Cheers.
Cheers, guys. Bye.
Bye.